So I want to start by establishing the principle of health as a human right, meaning health is not a privilege to be afforded by some and not others. No matter who you are, who your parents are, where you were born, live, how you identify or behave, you have the fundamental right to be healthy. And you have the right to be protected under the law against threats to your health, direct and indirect. And I bring this up because I think it's a point we can all agree on. We share the value of health above all else. From there, it's a natural extension to the concept of public health, the health of all of us as a collective also being a human rights issue. Populations, groups of people have a right to health in the same way as individuals do. And the moral, ethical, and rights-based arguments in favor of public health as a human right are obviously strong, but if you need more, consider that our economy is reliant on the health of the public. It runs on human capital. And that's our starting point. Health and public health are fundamental human rights, and they must be guaranteed and protected for the good of all people. If the past year has taught us anything, it is that our lives, our livelihoods, and our health are bound together. When the public's health is tenuous, and when the public's health suffers, we all suffer because we are all the public. We are, as the theme of this TEDx event states, interconnected. And the COVID-19 pandemic has made this exceedingly clear. It has exposed our nation's crumbling public health infrastructure and more broadly, our deprioritization of public health and the consequences associated with decades of underinvestment in public health. And the evidence is clear that those consequences have been borne very unevenly. For example, in the past 14 months, the COVID-19 pandemic has cut short nearly 600,000 American lives. And what that number by itself won't tell you is the following. Black Americans make up 13% of the US population, but they represent 22% of age-adjusted COVID deaths. Hispanic Americans make up 19% of the US population, but they represent 38% of age-adjusted COVID deaths. And white Americans, they make up 59% of the US population and represent 32% of age-adjusted COVID deaths. Those statistics describe racial and ethnic inequity in COVID deaths. Of course, inequity can be based on any variable, gender, income, zip code, and so on. And you'd be forgiven for thinking that inequality and inequity are the same things. They seem similar, yet there are some really important nuances. Equality is about sameness. Equity is about fairness. Inequality, not the same. Inequity, not the same, and also not fair. In the world of public health, we tend to think of equality as sameness in allocation. On the face of it, equality seems to promote fairness by giving everybody the same thing, the same intervention, for example. Critically, equality is agnostic. It is mathematical, that is non-judgmental, not critical of differences between groups. Contrast that with equity, which is sameness in outcome. Equity is when everybody ends up at the same place because they've had the same opportunity and resources to do so. Equity is an ethical principle. It is not agnostic, and it does make a judgment, and that makes equity much more difficult to study than a simple observational analysis. Because in seeking equity, we seek justice. Public health justice is when all people have equitable opportunities to achieve the best health possible, and health outcomes across groups are even, with no group bearing a disproportionate burden of disease. So what are the roots of equity? Complicated question, because what we're really asking is what are the roots of injustice? In the early years of my research career, I studied the developmental origins of disease. My colleagues and I examined the impact of early life and maternal factors in risk for disease later in life using relatively rare, large birth cohort studies from across the world. These are research studies that follow thousands of participants from birth over many years. And across countries and contexts, our findings were consistent. Children whose mothers had less education, lower income, or belonged to a minoritized racial or ethnic group were more likely to have poor health. They were more likely to have poor birth outcomes, be smaller as children, become overweight as adults, and have hypertension and diabetes as adults. Consequently, these children grew up sicker, completed fewer years of school, earned less money as adults, and the cycle continued. An unhealthy start to life yielded fewer opportunities to thrive over the life course and over generations. Root of inequity. Decades of research from US populations underscores how health inequities are linked to racism and discrimination. Compared to white populations, Black and Latino populations have higher stress hormone levels, chronic inflammation, blood pressure, and are more likely to have metabolic syndrome, even when statistically accounting for the effects of education and income. Meaning, these negative health outcomes represent the independent effect of being a person of color in the United States. Root of inequity. And that's not to mention the overt acts of social, cultural, and physical violence perpetuated against Black children and adults in schools, in the workplace, in communities across the country. Racism itself diminishes human capital and therefore the public's health. Root of inequity. As a scientific advisor to the California Office of Environmental Health Hazard Assessment, I evaluate the impact of toxic chemicals on agricultural workers and their families living in the Central Valley of California. These are largely Hispanic communities who produce nearly all of the fruits and vegetables for the entire country. And not only are they less likely to have access to the very crops they produce, but they are also exposed to chemicals that increase the risk of asthma, allergies, cancer, reproductive disorders. Root of inequity. According to the USDA, 14% of households with children do not have access to proper food. That number is 19% for Black households. It is 29% for households headed by single women, and 35% for households living below the poverty line. And years of research shows us that children who aren't properly fed can't study, have worse social skills, and are more likely to drop out of school, and subsequently less likely to have stable employment. Root of inequity. During the pandemic, 10% of low-wage jobs disappeared, compared to 3% of high-wage jobs. Root of inequity. A third of all wealth in the United States is concentrated in the hands of 1% of the population. Root of inequity. And these are just a few examples of the roots of inequity, and all of them are public health relevant. Structural, contextual, and political factors throughout life and over generations puts us as individuals and as populations at different starting points. These are the social determinants of health, and they are of such consequence, and they are so impactful to individual health and public health that they are often referred to as the causes of the causes. A reckoning is defined as a settling of accounts, but also the avenging of past mistakes. Our reckoning begins by accepting that by any assessment, our approach to health, public health, healthcare in the United States is ineffective at keeping the public healthy. The United States spends almost $4 trillion annually. That is $11 billion a day on healthcare at roughly 18% of GDP. This is twice as much as peer countries. And what do we get for it? The United States has the lowest life expectancy among the rich countries. The United States has the highest burden of chronic disease, heart disease, hypertension, diabetes, and Americans are twice as likely to have obesity. At the same time, public health funding represents about 2.5% of our federal health and human services budget. 2.5%. Between 2008 and 2017, we lost more than 55,000 jobs within local health departments, according to the Trust for America's Health. The number one reason for bankruptcy in the United States is medical expenses. That, by the way, is a moral bankruptcy. And poor people, marginalized people, people of color, the very populations that suffer the most social inequity, also suffer the highest rates of disease and the least access to care. Yet we focus on access to care and healthcare as the answer to our public health problems. And of course, this is a false equivalence because healthcare is where you turn when you are sick and need medical attention. You don't get sick because of a lack of healthcare. It is an explicit thing that we can point to and say, look, we've improved health when we really haven't. According to data from the Kaiser Family Foundation, the Affordable Care Act, which was billed as transformational, decreased the percent of uninsured people in the United States, decreased the number of people uninsured in the United States from about 45 million to 25 million. And poor populations, populations of color, benefited the most. Successful? Absolutely. But today, 1 in 10 Americans still lack access to basic health care. Successful, but not nearly enough. Our reckoning begins by focusing on what actually keeps people healthy. We must realize what public health is. Poverty is public health. Systemic racism is public health. Affordable housing is public health. Access to clean water is public health. Food and nutrition security is public health. Neighborhoods are public health. The justice system is public health. Climate change is public health. For all of these public health issues, we must first achieve equity for everyone to enjoy equality. Seems like a lot. It is, and for that reason, I'm not proposing any one action item. I propose a renaissance for public health. We are living in interesting times, consequential times, and I'm not just talking about the pandemic. All around us, the public are waking to no longer accept the historical and ongoing injustices in our communities. All around us, the public are protesting, marching, with a shared vision that all people should have equitable access to health, safety, and opportunity. This moment has galvanized us, and now we must leverage that energy, that momentum, to improve the public's health for all of us. I think first we have to accept that the equity-based approach by definition means treating populations differently based on where they are. And this contrasts with the mythical precept of equality or treating everyone the same, which is ingrained in our minds as the right thing to do. But some of our policies and programs already take the equity approach. We're doing this. We simply need to strengthen them, increase their reach, and make them more readily available for everyone. For example, our research lab found that many people simply don't know about federal food benefits or the Supplemental Nutrition Assistance Program, SNAP. And when we helped them sign up for benefits, participants experienced a 63% decrease in food insecurity over just a few months. They were able to fulfill their most basic need of eating properly. And I think those of us who have enough simply cannot fathom the impact of no longer having to constantly worry about whether there will be enough food money for the family. On the other hand, we found that many people who experienced dire need just did not qualify based on the eligibility criteria set forth by the federal government. So while we lobby and advocate for change at the policy level, we have to ensure that local communities are empowered to provide social safety nets for those who might otherwise fall through the cracks. In our community, for example, we work closely with a network of local food banks who can get food into the hands of the unhoused, undocumented, and others whose cases do not fit into conventional molds for public assistance. Each community knows their people best, and our renaissance begins with empowering communities with the resources and tools they need to best address their own needs. In public health, one size rarely fits all, so our strategies must remain innovative, adaptable, and seek justice for all. And this has to be done through bottom-up, top-down strategies, from locally driven community-based efforts to federal legislation. And for that to be effective, we must let the public drive the agenda. We must let science and evidence lead the way, and we must relentlessly push forward for the common good. Our renaissance begins with increasing public health funding significantly. We need public health infrastructure. We need investment in human capital through educational opportunities and workforce development. And we need system integration across federal, state, and local public health entities. And to see these things as key priorities, you don't have to look any further than the impact of the COVID-19 pandemic. Our renaissance begins with an aggressive and progressive health and all policies agenda that prioritizes the public's health above all else. And this goes for social policy, as well as housing, agricultural, justice system, and economic policies, because all policies impact the public's health. And finally, our renaissance begins with the knowledge that the power of making change is in our hands, the hands of the people. Whether you're involved in your local community, working with friends and neighbors, advocating on behalf of your community, lobbying your legislators for positive change, or even talking about equity, justice, and public health with your friends and colleagues, you are making positive change. Each one of the people you help educate, you help through their situation, and each one of the ripples that you create. And every time you make some good trouble, you are working on our renaissance to creating public health justice. And now let's all get back to work. Thanks very much.